webinar is about stimulated potential analysis using concentric needle electrodes, also known as SPACE, in pediatric EMG. And I'm delighted to introduce our speaker for today. Since 1990 and until recently, Dr. Matthew Pitt had been a consultant clinical neurophysiologist at Great Ormond Street Hospital for Children in London, UK. He is a well-known teacher and educator in pediatric EMG, chairing the International Pediatric EMG conferences, which have been running since 1997, just before we were chatting about this meeting, and apparently we are going to have one next year. He's a knowledge both internationally and nationally, as having some of the most extensive experience in pediatric EMG, seeing around 850 cases per year. He has established an international network of enthusiasts in pediatric EMG and has trained doctors from all over the world. His particular interests are in the use of stimulated single fiber EMG in children, investigation of dysphagia and obstetric brachial plexus palsy. He has been active in research with over 180 publications, of which 90 were full review papers. In addition, he has written 10 chapters and the first ever textbook dedicated to pediatric EMG. Dr. Pitt, I'll hand it over to you.
Well, thank you very much, Sladia. Kind introduction. I'm going to just, I'll just say hello to everybody now, and then what I'm going to do is I'm going to turn my video off so you can concentrate on the presentation. So, well, let's get started then. Okay. What I want to talk to you about is SPACE, which is, as Philomena said, stands for Stimulated Potential Analysis Using Concentric Needle Electrodes. And during the course of this talk, we'll explain why we use this term and explain some of the difficulties with the technique. We're talking about investigation of the neuromuscular junction here. Obviously, if you have an armament of neurophysiological techniques to look at the neuromuscular system, you need to have something to cover the neuromuscular junction. That's just a given. And myasthenia in children, either congenital or rarely the autoimmune form, is going to be your primary target. Now, the problem with neuromuscular junction disorders in children, and particularly the myasthenia, they're very rare. They're sometimes fatal, but they're often treatable. And in addition to that, you have a very variable and non-stereotype clinical presentation. So you can't really pick the cases that you think are likely to have it, which is different from adult myasthenia gravis. And then to add to all of this, you've got non-cooperative patients. So what you have to find is something that's easy to perform, universally applicable, irrespective of the age and where you're doing it, with a high sensitivity and specificity. And people say, well, you should do it under general anesthetic and let that be an answer to it. But I'm afraid that it's not really a suitable screening technique if it requires a general anesthetic. I certainly had great difficulty getting general anesthetic lists when I was at Great Ormond Street. It was one of the reasons that we developed this as a non-general anesthetic procedure. So what are the contenders for neuromuscular junction investigation? Well, everybody knows about repetitive nerve stimulation, but one of the things you must remember about this, it actually requires failure of transmission of the signal across the neuromuscular junction to be positive. And it can be uncomfortable, although there is some debate about this. I certainly find the children I do it on find it uncomfortable. Maybe just recap very, very quickly what I've said, maybe not necessarily going through them in detail. We talked about we need an investigation of the neuromuscular junction. Myasthenia is the primary target for that investigation. So we talked about the problem. We've got rare conditions, often fatal, can be treatable, non-cooperative children, non-stereotype clinical presentation. We need an easy to perform solution, universally applicable, irrespective of age and location, high sensitivity and specificity. And I gave you a reason why I think that anesthetic is not an answer. We've talked very quickly about repetitive nerve stimulation, and we were coming on to the two single fiber options, one of which is volitional, which is difficult to perform. I don't do it enough to even try it, and I do occasionally see people sending me results in 2-year-olds, which are beautiful, but I couldn't pretend that I can do this on every single child, and I think that's the most important thing, that you might be able to do it, but you can't consistently. So stimulated single fiber EMG is actually really the preferred option. Let's just quickly go over a bit of the physiology with physiologists featuring strongly in the audience. This will be second nature to many of you. Here we have a schematic showing a muscle action potential being recorded from a concentric needle electrode placed into a motor unit with muscle fibers distributed as shown on the left. And the important thing to remember, and this will come to be important when we talk about the effect of filters, is that the nearer the muscle fiber is to the recording potential, the sharper and larger is the action potential seen. The action potentials from each of the muscle fibers we can assume are similar, and therefore the ones that are being recorded from furthest away from the needle, as you can see, are attenuated with more low frequency components and less amplitude. Obviously, when you mix these all together and produce the muscle unit potential, they all coalesce to form the motor unit potential. So the principle of single fiber EMG is that you try and isolate only those muscle fibers closest to the needle. And there's two ways you can do this. One is by having a very, very small aperture for the needle itself, or attenuating the low frequency filters so that there's attenuating low frequency components by a low frequency filter that prevents those contributing to the motor unit potential. So what happens here is that here you have those two muscle fibers from a single motor unit being stimulated in a situation when we're doing volitional single fiber EMG, and each of them will show variability in the action potential on repeated firing, and this is shown as a jitter. If you hold one of those potentials with a trigger, then the other potential will demonstrate the variability of the two units. So a single fiber EMG, volitional EMG, is actually measuring the jitter from two neuromuscular junctions. Clearly, if something goes wrong, here's an example. This is actually due to disturbance in the nerve, and you will see that the variability becomes increased, and occasionally you have a failure of conduction causing blocking. Now, this is really the most important slide from the ones we've looked at so far, because it demonstrates why single fiber EMG is to be preferred for analysis of neuromuscular junction compared to repetitive nerve stimulation. The time taken to reach depolarization, shown in this graph as the potential rises up to -30 and then causes an all or nothing response, is directly proportional to the effective concentration of acetylcholine at the neuromuscular junction. Now, when I say effective concentration, it's not the exact concentration being released or being received, but it's not the exact concentration being released, but how much actually reaches the neuromuscular junction. So you could have a situation where the neuromuscular junction, the postsynaptic membrane, is disturbed, and therefore the effective concentration is reduced, or you could have a reduction in the concentration of acetylcholine being released in the presynaptic region. Now, as it's reduced, so the variability and the speed with which this depolarization is achieved varies, and this is what is shown on the slide on section B. And there you see an increased variability, which will be demonstrated by increased jitter. The important point here is that there has been no block, there has been no failure of transmission, which is required to have an abnormality on repetitive nerve stimulation. So physiologically, stimulated as a single fiber EMG is going to be more sensitive to disorders of the neuromuscular junction than repetitive nerve stimulation. And this is backed up by clinical studies. We mentioned about the needles. At the bottom, you see the single fiber EMG needle invented by Eric Storberg, and you see the tiny area of its recording surface. This obviously will restrict the number of fibers from a distance, and is the primary and the correct needle to use in single fiber EMG. However, and we don't use it, and I'll explain why, and instead we use the concentric facial needle electrode, which has a small area compared with the concentric standard needle electrode, but several orders of magnitude greater than the single fiber EMG. So why do we use it? Well, when I started doing this some years ago, we were not allowed to use reusable electrodes. This was a drive which is almost globally followed, I think, following various prion infections, etc. And at that time, the single fiber EMG electrode was expensive and had to be reused. So we were not allowed to do that. So we then had to use a facial needle, which is the needle I use for all pediatric EMG, and that's the way we do it. When I've used single fiber EMG, the needle is slightly larger than a facial needle. That isn't necessarily something against it, but the other point which makes it difficult to use it in particularly babies, even when we are now seeing single-use single fiber electrodes, is that the side port is set back from the needle tip. And if you're doing an EMG in a very small baby with a very thin orbicularis oculi, there is a possibility that you cannot advance the needle further because of bone interfering with that, and the side port could still be outside the muscle. With a facial needle, with the recording surface at the tip, this isn't a problem. So here's the theory of stimulated single fiber EMG. On the left, we see a needle inserted close to the nerve bundle. And then in this example, we have four different types, or 4 different motor unit contributors. And these, for example, the yellow motor unit has 2, the red has 3 muscle fibers, and the blue 2. And these can produce action potentials, which are shown on the right. The important thing to remember about this is the action potentials come from different motor units. Some of them will come from the same, but there's absolutely no way of knowing which ones are. So you cannot measure the jitter between the muscle, between the action potentials, instead of which you measure it in relation to the stimulus, the start of the stimulus. So in stimulated single fiber EMG, you're measuring jitter from one neuromuscular junction. And here's a picture of how it's done. This is a little baby of about, I can't remember, about 2, I think. And we've used local anesthetic cream. Ametop is the preferred choice. You can use Emla, it just takes a little longer. Ametop can be used to very young age, I think even down to a month of age, whereas Emla is not allowed below a year. We put the cream on, send the child away for half an hour, and then when they come back, we place these 2 needles. The bottom needle is a monopolar needle, the same diameter as a facial needle. It's placed just above the zygomatic arch, halfway between the tragus and the outer canthus of the eye. A trick to make sure this is not uncomfortable is to press your finger against the zygomatic arch at the same time as introducing the needle, because the ametop cuts the sting, but they still feel the pressure. So often you can put that in without the children feeling it, and a similar technique of pressing the bone before you put the needle in is used for the recording electrode shown there. We have a indifferent electrode just below the ear and an earth electrode up on the forehead. So a few technical details about the technique. The settings, the filter settings are from 3 kilohertz to 10 kilohertz. We're going to discuss that in a minute. Stimulation duration is 0.04 seconds. And the stimulus intensity, you should aim for less than 1 milliamp. And when I'm training people, I really insist that they get potentials at lower than 1 milliamp. And the reason for this is if you need a bigger stimulus, it usually means you're not close enough to the facial nerve. And this means that if you see jitter, you may be seeing a technical problem because of the poor quality of the stimulus. So that's a really important point. And also, it's very much more comfortable for the children. We've sometimes seen it with 0.2 of the milliamp. So it's really possible to do this. We use a peak detection algorithm on the program that we have, and everything I say about the recording, the filter settings, and everything is relevant only to peak detection algorithm programs. I tend to record 20 sweeps once I get the potential, and I aim to get more than 20 potential jitter measurements. Now, I know people say, well, you have to record a great number of sweeps, more than 20 for sure. It's sometimes just not possible, and I think some people say you need 100 sweeps. I actually think it's quite difficult to get that number in a cooperative adult, so I'm happy with that. We tend to stimulate at 10 hertz, so it's quickly done, and that's important. Again, the number of potential jitter measurements that you need varies. Some would say 20 is not enough, but the important thing with children, I think perhaps more so with adults, is if it's abnormal, you pretty quickly know it's abnormal. So you don't often need to pursue a very exhaustive study to prove that. Just now, let's talk about filters very quickly, because this is a fairly controversial element to stimulated single fiber EMG. This is a paper written by my mentor, Peter Payan, and he described it as the blanket principle. And he was using standard concentric needle electrodes. And what he was trying to demonstrate, and showing quite nicely here, was that if you increase the low frequency filter to 3.2 kilohertz, I think it was chosen because that was one of the settings on the Medilec machine that he used, you can actually see some of the detail within the motor unit potential. And this is shown here from a series of recordings from a 70-year-old woman with chronic polymyositis. The first is the standard filter setting, standard sweep. You then stretch it out a bit more on the second picture. You don't see any complexity or instability, but when you increase the low frequency filter, you can see quite marked abnormalities. Now, Peter taught me when I started, and in fact, I used to go and spend a morning with him for the first 3 or 4 years of my time at Great Ormond Street, and it was a wonderful experience to be able to sit and watch an expert doing these studies. And he used to, because of his training in Uppsala and in Copenhagen, he was a master at triggering motor units, and then he would quickly flick the low frequency on and be able to tell you if there was jitter abnormalities. He didn't really record jitter, but he made qualitative assessments. So this is why I was sort of led into using this relatively high level of 3 kilohertz for my studies. People have criticized this, and I suspect rightly too, but we did a study published some years ago now where we changed the filter settings for a patient having stimulated single fiber EMG, going from 500 hertz, which is the recommended, certainly for a single fiber EMG needle, but also in other people's experience of using facial needles. And we went up to the level we use. And using a peak detection algorithm, we found that we didn't see any change in the measurements. So we were encouraged that this did not distort the results. The interesting thing is, as you increase the filter, increase the level of the low frequency filter, you often get more complexity, more potentials appear. And one of the worries is that they are too small and that you lose the amplitude, but we didn't find that as a problem. So we feel encouraged that we're not doing something terrible by using 3 kilohertz. It does produce a more stable baseline, and it does in many ways produce more potentials that you can analyze. So why space? The important thing about space, or stimulated single fiber EMG, is that very few potentials have their origins from single muscle fibers. This is because there is overlap of potentials from different fibers, which is very difficult to prevent in a situation where you're stimulating the nerve. And the other thing, of course, is that I will show in a minute that as you get increasing abnormalities of jitter, this just gets worse. You get more and more overlap potentials, which leads to all kinds of problems with interpretation of the results. So for those reasons alone, single fiber seems inappropriate to describe this technique. And also, single fiber methodology is well established and has very strict criteria, and we are not using those, and I think it's wrong to give that in the title because people will assume you are. So we thought a long time about how to put this into a catchy acronym, and John McHugh, who was a fellow with me some years ago, came up with SPACE, which I'm indebted to him for, and this stood for stimulated, so that's no debate. Potential analysis, I hope you agree that's accurate, using concentric needle electrodes. I think it accurately describes what it's done. It makes no reference to single fiber EMG, and it allows the technique to have origins other than single fiber methodology. And it's a natural progression from the blanket principle, which I would never have used if I hadn't been taught by Peter Pyer. What is it we're measuring? Jitter is the term given to mean consecutive different measurements with single fiber EMG. Jiggle is another thing altogether. So we tend to prefer MCD as a neutral term and use that. Now, the measurement of the MCD is where things begin or to get difficult and the wheel begins to come off the wagon. As many of you will know, there are very strict criteria of what determines a potential that can be measured. And a lot of work has been done, and a lot of publications on this, and very clear guidelines as to what potential what the shape of the potential, whether it has a shoulder, etc., and whether you can or cannot use it, whether it's separated from other potentials. We don't tend to follow those rules because, as you'll see quickly, they would actually prevent you recording anything in many ways. So here are the problems. It's very difficult to reduce the number of potentials. I've toyed with the idea of, wouldn't it be wonderful if we could just get 2 or 3 potentials? But mostly when you do the technique, you get a profusion of potentials, which is great because it means you can record a large number of results, but it means that the possibility of overlap is increased. So many of them are composites of several fibers. So these are not single fiber potentials. These are small motor unit potentials. So it's very easy to measure jitter if the study is normal. I think this shows this is a nice study. We've got only 3 potentials here, and they might even fulfill all the criteria for a single fiber potential. They're still likely to be composites of several fibers. This is a slide that I often show, and on the left-hand side, I defy you to identify really any of these potentials as being single fiber potentials by the definitions published. And it's really, really difficult to satisfy the criteria. And as you see, maybe potential 3, but even there, the shape does vary a little bit. The rest of them are more or less unusable by strict criteria. The question I have for you is the test abnormal? Does it actually show an abnormality of the neuromuscular junction as demonstrated by increased variability of these potentials? And I think the answer has to be yes. But what about this one? I mean, what do you do here? It's clearly impossible to measure with any degree of accuracy what is going on here. And if you put this through the computer program, you'll get values of over 100 microseconds for the jitter. Now, what I do with these ones, the one on the right obviously will give you something approaching near normal. I just put the value as the computer produces it, knowing full well that there's no way that you can accurately say this is at 120 is 4 times more abnormal than one at 30 microseconds, for example. So there are the problems of the data you get. Now the next thing is, how do you know what is normal? And I have to give acknowledgement to my friend Joe Jabry for his help determining normal data using e-norms. Now, I don't want to spend too much time on this, but you do need to understand a little bit about the methodology. If you go to your computer and produce a random number generator with criteria of a mean of 20 and standard deviation of 1, you will produce 1,000 random numbers. If you align those numbers in ascending order of magnitude and plot them with the scale on the left-hand side showing that, you will see that you have an S-shaped curve. And on the right-hand side, what we have done is we've taken the first order difference. That is the difference between number 1 and number 2 and number 3, and so on up to 990, 99 and 1,000, and plot these out. And what happens really, I suppose, on the bell-shaped end of a normal distribution is that the first order difference tends to increase as you get closer to 2 standard deviations. Now, you can do this yourself and see how it works, but it's very easily applicable. And what you find is that you can identify at the points of inflection 2 standard deviations of the population. So here we were 20 mean plus or minus 2, and as you can see, the range here is from 18 to 22. Now, the great thing about this, and so useful in children, is that you can apply it to your clinic population, irrespective of whether they're normal or abnormal. And this is what we did to a group of adults, data kindly supplied to me by my colleague and co-author Jackie Deeb, and we took 82 adults from 21 to 56, and we found that the upper limit was around 26. This is a study from our cumulative data of 657 children. And before we did this, we were sort of using the adult upper limit of 26 from other studies rather than e-norm. And this seemed to work very well, but we never had any proof that this was correct. One of the most astonishing things about my work on the single fiber is just how mature the neuromuscular junction is in children. I did have a 16-week-old baby who had a jitter measurement of 20. So there is something quite extraordinary about this. And so we were pretty comfortable using 26, even though it was the adult. But when we did this study, we had some further support that this was a reasonable thing to do. If you look at the data available, and remember that you have to multiply the single fiber voluntary data by a factor to compensate for only one neuromuscular junction being contributing, you do find that the meta-analysis does produce an upper limit of 26 and an upper limit of individual measurements at 34, which is actually what we use. And this is a paper by Eric. And I've met this guy and I never can pronounce his name. I do apologize. From Brazil. He gave me a Brazilian football shirt last time I met. Anyway, the point is that the MCD was confirmed in a standard, absolutely normal control study, taking 50 healthy subjects, so irreproachable. For a long time, we carried on thinking that the 26 was okay, right to the lower age group, but I think we were surprised by that. So we did some further analysis, and indeed, when we looked at it a little bit more closely, it seemed that under 1 year of age do tend to have a slightly higher upper range of jitter, although the impression I get is there are some children who are very mature, like this child with a jitter measurement of 20 at 6 weeks of age, and those that perhaps are just a little less mature, who perhaps would not reach the upper limit of 45 shown there, but might be above 26. But gradually over 2 years, they return to the normal value. So these are the values we use for measurement. So what do you do with the data when you get it from your analysis? There's not an awful lot to do, but I'll just explain a couple of things you should do. The first thing is that when you're stimulating, what I tend to do is I give a single stimulation and gradually increase the stimulus intensity until I get a response. I then reduce the stimulus intensity to 0 and then put a train of stimuli on at 10 hertz. Obviously, when you do that, when you reach the threshold, you will start to see the potentials. Before that, you will have nothing. So once the potentials have been recruited, I collect one screenful. So when we come to the analysis, I will remove everything before that one screen. So what you're then left with is the proper data at the threshold you encounter. You then go, when you're doing technically, you then move to another area, use another stimulus and collect another population. You mustn't just keep collecting from the same place. And this is an example of showing you where you are most probably not going to use these two groups as two different populations, because as you see, they're almost identical. And the way to know this is to look at the latency of the potentials rather than anything else. So this one is a 2.7 above 4.1, 3.2. There's enough similarity here to suggest that this is the same population, slightly different in its recording, and the best thing to do is eliminate one of these. That way you can continue to make an analysis which is statistically okay. The other thing you sometimes get is you get the peak detection algorithm not being able to distinguish between two peaks. And here we have a little bit difficult to see on the big screen, but if you look at the bottom right, where the peaks are shown with a pink dot, you'll see that in two instances on this screen, there are potentials that are much closer to the stimulus start than others. And this is shown in the next slide. And you can see here that what it's doing, the program is popping between different peaks. And the second one down it's taking the first one, and then the rest it's taking the second one. Now, this is going to produce a jitter measurement, which is entirely fallacious, just produced from the computer itself. the two things you can do, you can either go through and select each of those that are not from the one you want and remove them, or if you've got a lot of potentials, just simply not use that one at all. That's really the only two things you must look out for. So clinical application. I'm a bit out of date now with congenital myasthenia because it seems to me that almost every month a new genetic abnormality has been recorded and described. So this is a picture of a neuromuscular junction with various known genetic protein abnormalities identified, and these will be expanding by leaps and bounds. So it's a very complicated and very specialized field, but as I say, there are a large number of potential disorders. This is another picture of just the musk part of the equation. But the good thing about this is that even though you have this huge number of different genetic defects, they actually fall into three major groups. And on the right-hand side of this pie chart, you will see acetylcholine receptor deficiency of the epsilon element of the acetylcholine receptor. The next most common is rapsin, and the third is DOX7. Long way behind that is the slow channel abnormality, and then a range of other things. So even though there's a large number, there are three major groups that constitute most of them. Now the next question is, what else causes jitter? Not all that jitters is gold, and let's just remind ourselves of the actual physiology that is in operation when you use stimulated single fiber EMG. Clearly on the left-hand side of the diagram would be the signal coming down from the stimulating needle, and then the recording of the potentials from the other needle. And clearly the nerve itself could cause a problem, terminal nerve fibers, the neuromuscular junction, the muscle itself. All of these could produce a jitter abnormality. So how can we work with this? Well, it would be nice if we, allowing for all the difficulties of measurement, could say that if a jitter measurement is between a certain point and another, it's likely that one condition is causing it, or if a different range, another condition. And this is a stylized, idealized view of this, where conditions A to E are separated by clear levels of lower and upper limits, and then everything would be fine, and we could tell the clinicians exactly what's causing the jitter abnormality. Of course, reality is always different to the stylized ideal world, and you can see here what commonly happens. And if you look at a group of cases amongst the many cases we saw, you can see that there is not only wide variability amongst the myasthenic conditions, but also in other conditions which complicate it. So, for example, musk seems strangely has a limited range. CoQ is off the scale, as is rapsin, with levels of extending right from almost normal to completely abnormal. Myopathy rarely is very abnormal, but anterior horn cell disease, and this is really important to remember, can be very abnormal indeed. So sensitivity, we looked at this some years ago before we had the 657, and we looked at the 508 patients looking at the diagnosis of myasthenia definite or probable. And sensitivity was 98%, which is wonderful. The negative predictive value, I would just stress here, was also very high. And that's a really important point about this technique, because if it's normal, it's highly unlikely that the patient has myasthenia. It doesn't mean they don't have it, but it's highly unlikely. And the clinical colleagues that I've worked with over the years found that in many ways some of the most useful information they got from this technique. Now, the specificity here is not particularly good. It's 158 over 378, which equates to 41%. Now, so I just said really gone over this, but we wrote this some little time ago now, 2017, and this was, I suppose, the final sort of summary of all our experience, and I'm indebted to my colleagues listed there for all their hard work. And what we did is we took our measurements and we did a receiver operator curve, which I'm sure many of you are familiar with, maybe more so than I am. And essentially, you try and determine from the curve what is the best trade-off between sensitivity and specificity. And the point we've identified on the curve there corresponds to a mean consecutive difference index of 115%. So what we did is we found the MCD which we recorded from the patient, and we divided it by the upper limit for that age range. So for many cases, that would be 26. So what we found is that, and this is shown in the next slide, and you can see here the different conditions with the box plot of the range. So on the left, you see an abnormality of the neuromuscular junction, and then other candidates for abnormality of the jitter of the MCD shown on the right. But if you see at the bottom here, at the MCD-I of greater than 115, the sensitivity has dropped from 84%, but the specificity, which was much better here in some ways than it was in the first study, has risen to 84%, which is, I think, pretty good. So, so that's what we use as our cutoff point for recommending to our clinical colleagues what they should do with the results. And the way we worked this was that if it was under 115%, we told our colleagues that it's possible that myasthenia might be causing it, but other causes should be explored first. So look for a myopathy, look for other things. But if it's over 115%, we found that it was worthwhile them pursuing and continuing to pursue myasthenia as a diagnosis. The situation often with the clinical examination and investigation of these children is that the clinicians will do the big three first. They will determine which of the three major causes are likely. And if it's not any of those three, what then happens is they're then confronted with the possibility of quite expensive and quite long investigation to determine if any of the other more rare congenital myasthenic syndromes are the cause. And if they're supported by a jitter measurement which is over 115% of the MCD-I, this gives them more encouragement to pursue this than if it was lower. So I hope that's the way it's used. Now, just to remind you, at the very beginning, we talked about how if you had an adult, it's quite easy to sort of, well, easy maybe not, but it's relatively easy to diagnose somebody with myasthenia. And in fact, many places will go straight to the antibody test before doing physiology. Patients present with ptosis or swallowing difficulty, but such luxuries are not really available in children because almost anything seems to be possible to be discovered in myasthenia, and a list of those is shown on the left. And then just to remind ourselves that other conditions can and are known to be associated with abnormal jitter. So the myopathies that have been well described are shown here. Neurogenic abnormalities are crucially important particularly the isolated bulbar palsy, because we quite often find that we see abnormalities in babies, particularly, who then turn out not to have myasthenia at all, but a bulbar palsy. And it's really important that you exclude that before you make a conclusion of myasthenia. And we discovered some years ago, because the Prader-Willi syndrome children we had seen presented with respiratory difficulty, and that's one of the keys or a sort of prompt for us to do single fiber, and we discovered quite a few, certainly more than 30%, who had jitter abnormalities. It's interesting, of course, Prader-Willi has associated fatigue, and it may be that the neuromuscular junction abnormality is a key to a possible treatment, but we weren't able to further determine how frequently it's seen. Prader-Willi patients weren't necessarily, not unreasonably, keen to be examined for no good reason. The other point, of course, is another group was the central hyperventilation syndrome, FOX2B being the genetic abnormality. And again, these patients could present with breathing difficulty, as some myasthenics can, and that's the reason we did just a measurement. So we've got a technique here which I would encourage you to use. It is easy to do. You're not going to get it right every time immediately, but it is possible to do. It's quick. You can do it quickly. It's well tolerated, and the results are fairly easy to interpret, whether being abnormal or not abnormal. We've discussed how it can be abnormal and not be due to myasthenia. And I want now just to encourage you to think of ways that you can perhaps eliminate those from your differential diagnosis. So this is a sort of algorithm that we worked on for some time, and I do still follow it, although the bottom section is perhaps a little bit more difficult to be sure of what you're seeing. The first thing is that if you have an abnormal space, first thing is if you don't have an abnormal space and the child is weak, you just go off and do what you normally do for a weak floppy baby or a floppy child or a weak adolescent or whatever. But if it's abnormal, what I insist you do is that you check that there isn't a bulbar palsy. And this is most easily accomplished by just placing the needle into the tongue using the submental approach, which often is easily done after the child has finished with the space examination. The child is already lying with its head towards you, often with the head slightly extended. So it's not at all difficult just to quickly check that the bulbar palsy is not the cause of the problem. And if the bulbar palsy is present, you are then obliged to determine if this is an isolated bulbar palsy or is this part of a motor neuronopathy. Because as you know, SMA has, for example, one motor neuronopathy which is important, clear indications of involvement of the neuromuscular junction. Now, the next step, most probably for some people, is completely crazy, because why don't you do this first? But if you don't have a bulbar palsy, but you've got an abnormal space, I would recommend that you then do repetitive nerve stimulation. Now, if it's abnormal, and you know for the reasons I've explained why it might not be, then you really are home and dry, and this patient will have myasthenia. Now, the critical amongst you would say, well, why didn't you do that in the first place? You're going to pick up a fair proportion of the patients with myasthenia, and then you can, if you still think it's myasthenia, you can do the single fiber. Well, I don't, I've never really had the luxury of multiple clinical appointments for patients with EMG. And basically, you have to get everything right the first time you see them, because it may be the only time you will see them. If you do repetitive nerve stimulation as the first or one of your first examinations, regretfully, because in my hands it's uncomfortable, any cooperation with other techniques like single fiber may have disappeared. I always do the single fiber space first. It's done when the child has the local anesthetic, the parents are not at that point worn out by the trauma of everything, and you are setting the scene for the most likely successful outcome. So doing repetitive nerve stimulation, unfortunately, doesn't fit into that pre-preparation. But if you do it now, then if it's positive, then you're home and dry. There's definitely myasthenia. The next is a little bit more difficult to support by the numbers. But if you have normal repetitive nerve stimulation, so if any abnormality of the jitter from myasthenia is mild, you would expect that the EMG will not be myopathic. You know that if you have an EMG that's myopathic in myasthenia, this will be because of block in some of the nerve fibers to some of the muscle fibers. So you get a sort of virtual myopathy because of the block. So if you know that the block is not severe because repetitive nerve stimulation is not abnormal, but you still see a myopathic EMG, the chances are it's more likely a myopathy than myasthenia. We put numbers to this some years ago. When you get to the very bottom, it's quite difficult. EMG diagnosis of myopathy in children is pretty difficult. So you're in difficult grounds there, but it's, I think, a strategy worth following. Now, a couple of other quick pointers on things you might help you when you're doing this. This is a child who I remember very well. She was about, so I remember very well, but I can't remember her age. She was a teenager, and we started doing the study, and we got these lovely potentials, which were reproducible on the second slide. And then I was just about to think, well, we've done all we need to do on this child. And the next slide showed the most extraordinary potentials, because in slide 3, you've got the first 3 are completely normal. And then you have a situation where you have block, highly abnormal jitter for the next 2 potentials, and then the finals potential is normal again. And then looking at another point, we again found this. Now this is the space marker of DOC7, which is one of the important myasthenic groups you'll see. And it actually reflects what you see in the pathology. Talking to a pathologist, he said, the neuromuscular junctions in DOC7 are classic. There are lots of normal, and then you find one area where they're completely destroyed. And this is a clear marker. So this child, I can't remember if the jitter was normal, even with allowing for this, but this finding was enough to say to people, this is DOC7. And when you're right, they never forget you. The other thing, of course, is you do need to do other studies as part of your examination. And this is a slide showing a repetitive CMAP in a slow channel myasthenic syndrome. Now, repetitive CMAPs are talked about as being absolutely diagnostic of slow channel syndrome and acetylcholine receptor antibody, the acetylcholine esterase abnormality. But the truth is that they can be very difficult to find. You must make sure that the child is not fatigued when you do it, because they are very susceptible to fatigue, as shown in slide B, where the very small repetitive CMAP quickly disappears. So if the child has been struggling or you've been stimulating for some reason, you may miss it. And I've certainly had experience of not being able to find it in a child who had a family history of slow channel syndrome and was later diagnosed with it. So that's just a cautionary tale. So we come to the end. No test is ideal for the diagnosis of myasthenia. I think we have to acknowledge that. If you believe it's more important to pick up cases because of their rarity, and you accept that you may get it wrong sometimes, I would say you have to use space. But if you're really over concerned about overdiagnosis, and I would recommend that you don't have that concern, use repetitive nerve stimulation. But best of all, I think an intelligent combination of both techniques and a full EMG examination is the way forward, and using the algorithm I've outlined, I believe, is a valuable way to proceed. Well, thank you very much for your attention.
We are going now to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit your questions through the question box in your attendee control panel. I'm going to hand it over to my colleagues, Antonin and Sanjeev, to start posing the questions.
Thank you, Philomena, and thank you, Matthew, for a wonderful talk. We have a question/correction in your slide. Your filter setting said it was 3 Hz to 10 kilohertz. We assume it meant 3 kilohertz to 10 kilohertz. I will not mention the name of the person who has said that question. You know him very well.
Yeah. Thanks, Eric.
Anyway, a couple of questions. I will take 1 or 2, and then Antonin can take. One of the questions that came was, you showed a picture of space with needle stimulation. Is it possible to do the stimulation using a surface electrode?
Yes, it is possible. My good friend Kerry Mills, who's retired as a professor in Oxford, used to do that, certainly in adults, and he had good success. The reason I actually went against it, it's actually more uncomfortable to stimulate on the surface than it is to use a needle, and I think that's the one important thing. And the other thing is that children have been known to move during this procedure, and the needle is secure during any movements, and I'm not sure I would be so confident with a sticky electrode stimulating. So 2 reasons. One is it's more uncomfortable, and the second is you get a better, more effective stimulus.
Thank you very much. Antonin, do you have a question?
We always do have questions. One question that was asked was really on the practical aspect of performing space. The question was, how often do you change the position of the stimulating needle?
Right. Okay. Well, that's really, really important. The way I didn't go into huge detail, but now is a chance to maybe take you through it step by step. When you bring the child in, you take the local anesthetic off, you put your surface electrodes on, the child is lying on a pillow, the family are as near to them as they can be. If it's a baby, the child is on the mother's lap. The first thing you do is put the stimulating electrode into where you think is the best position, and then you gradually increase the stimulus intensity. You haven't put the other needle in at this point, and you try and elicit a blink, and you want to be sure that that is less than 1 milliamp. If you see a blink at less than 1 milliamp, then you know that you're in the right position, and then you can place your recording electrode anticipating success. Sometimes in babies you don't get the blink even when you're in a good position. But the important thing is, if you don't get a good response under 1 milliamp, you have to have the courage to move it. Yeah, the important thing is don't just carry on hoping that it will all get better, because it won't. So what you need to do is say, I didn't get it right there, I'm going to move it. And the point is that the skin is anesthetized, and if you use the technique which I described of using your finger pressing against the zygomatic arch to distract the child from the pressure of the needle going in, it's often performed painlessly. But you know, we've all been there. It's all going badly wrong. The parents are upset, the child is upset, the people helping you think you're mad, but you just need to carry on. The most disastrous result of a single fiber EMG examination is that you don't complete it, because often you won't see the children again. Okay.
Excellent, thank you very much. Another question that just came in is, so I will literally read the question, which states, is there any more methods to diagnose myopathy in children? In adults, visual pattern is quite obvious sometimes, but not always. What's your take on this?
So a diagnosis of myopathy in children? What's my view on it?
Mm-hmm.
Is that what it's saying, Antonine?
Yes, if there are other methods to diagnose the myopathy in children.
What, other than needle EMG?
Mm-hmm.
Yeah. Myopathy in children is a bit of a nightmare to an electromyographer. It's the problem is that I work very closely with Francesco Montoni and the neuromuscular team at Great Ormond Street, who were hard taskmasters, very fine people and very good friends, but hard taskmasters. And the problem was simply that we never saw easy myopathies. All the ones that you read about in the textbooks with, you know, classic early recruitment, small fibers, fullness of the interference pattern, don't come the way of a pediatric electromyographer. The ones you're seeing are where there is doubt. There's doubt whether there's anything wrong with them at all, and if there is anything wrong, it's going to be a subtle myopathy. So trying to be accurate and be specific on your examination was really, really difficult, and I got it wrong many times. I've moved from what I used to regard as a sort of mosquito technique of just sticking the needle in and quickly having a look and thinking, oh, well, that looks myopathic or not, because it's so easy to see a child's interference pattern with small muscle fibers and think it's myopathy. So I rely very heavily on motor unit potential analysis and measure the duration of the motor units, and I do this obsessionally. And it's the only way I can feel confident that at least I've got some data to support my impression. So I'm very, very enthusiastic about that. And I will, when I'm doing an EMG, I don't look at many muscles. I maybe look at anterior, tibialis anterior only, but I will maybe spend up to 5 minutes sampling there to be sure to get potentials. Not easy with children sometimes, but if you wait, you do get that. So that's my take. It's very difficult, I think, to be honest with you. But the neuromuscular team get it wrong just as well clinically as I do neurophysiologically.
Brilliant. Thank you for your insight and your honesty there. Sanjeev, one final question for you.
Yep, we have one final question. Where can we find your textbook? Where can we get it?
Oh, it was on Amazon last time. I saw
okay,
it.
so
in fact, there were used copies on the day it was released, which I was a bit concerned about because people have obviously read it and sent it straight back. But there we go. No, yeah, it's on Amazon.
It's a wonderful resource. I have read it. I have his autographed copy. So again, for questions such as myopathies and different types of palsies in children, it's a wonderful resource. Matthew, thank you again for a very engaging talk. I have heard it before, and every time I pick up a little bit new. Thank you, everyone. Thank you for your participation.